So, of course, I'm Ryan O'Connor. I'm the optometrist at Ashburton Eyecare. If you are a local in Ashburton and um, get the Guardian, or you've just been on our Facebook page, you would have seen the article I wrote last month titled Understanding and Managing Glaucoma in the Ask the Expert feature in the Guardian. So, this is just a wee webinar to sort of communicate that in a little bit more detail. So this webinar is titled Understanding and Managing Glaucoma, Protect Your Vision with Ashburton Eyecare. So what we want to cover is understanding and managing glaucoma. Obviously, the context of glaucoma is that glaucoma is a serious eye condition and it can lead to vision loss if you've got a family history. So that's a direct relative. It can increase the risk by up to 80%. We have, or part of my role is a honorary teaching fellow with the University of Auckland's Faculty of Medical and Health Sciences School of Optometry, which is of course where I got my degree. Part of that is we have external placements for final year optometry students. We've got Hana Shin with us here at the moment, and we're going to have two more over the next couple of months. So if you're coming into Ashburton Eyecare for a routine exam, you may have your exam done by a final year optometry student. Obviously, I'll be overseeing their work. But yeah, that's an awesome service that we get to offer the students and also help them to see more of New Zealand. There's often a shortage of optometrists, especially in rural areas such as Ashburton. And it's great to show them what's on offer in places like Ashburton and just how full scope optometry can work. And that's what we pride ourselves on at Ashburton Eyecare, being therapeutic optometrists, giving full scope care to anybody. And already Hannah's talked about the wide array of things that she's already seen in her first 2 days. But anyway, we were talking about how they were discussing at university recently that there's a 25% risk, so absolute risk as opposed to increased risk, absolute risk if your parent has it, and then for every sibling you might want to add another absolute 10% risk to the risk of having glaucoma yourself. Unfortunately, the key problem with glaucoma is it's often called the silent thief of sight, and that is because you can lose about 50% of your nerve before you actually notice that your peripheral vision is gone. So that is the difficulty. And what we'll get out of this webinar is the understanding of how we can capture glaucoma and glaucoma risk far, far earlier without anybody needing to go blind and losing their driver's license, and all of the sort of impacts of life that come with losing your peripheral vision. It obviously increases the risk of falls and damage, so damaging yourself and the mortality risks that come with that. Obviously, there's social impacts of not being able to drive and the dependence on other people when you're unable to drive, and also the drop in contrast sensitivity of your vision, which means that even though you may have got your cataracts replaced, you have the optimal focal capacity from your lenses, however that may be. As many people know, often post cataract surgery you don't actually need glasses, depending on the focal length you're looking at. But despite having the correct focus, your vision is poor, so you might also not have the quality of vision to be able to see the driving standard, which is twice that of 2020. And so trying to read, trying to watch TV, even though you've got central vision, it's poor central vision and has poor contrast. So those are some of the impacts of glaucoma. So we just spoke about that those loss of nerves, which is what glaucoma is, it's a progressive loss of nerve over time, impacts somebody's visual field, so their ability to see things in the periphery or identify or track things in the periphery, and then also contrast sensitivity. So the difference between edges of stuff. And so if you're looking at this slide, obviously we've got a very high contrast image there of the Ashburton Eyecare blue on white. But despite that, your brain can't see those edges so well, and so the two blend into one another, and it's difficult to figure things out. So that's what makes it hard to read and sort of drive and see stuff on a TV and that sort of stuff. So that is when there's advanced glaucoma, and that's what we're trying to avoid. Prior to that, there's very minimal signs or symptoms of glaucoma. Sorry, there are signs. There are very many minimal symptoms of glaucoma. As it's getting along, somebody might start to notice that dullness. They might sort of see things around lights, not quite so sharp, but there is not a lot. Glaucoma is associated with migraines, so someone with migraines might be a sort of a symptom, something for us to look out for. But there is this key one here that is an angle closure attack. So I should put a diagram in of this one. Our cornea, which is the clear window at the front of the eye, and our iris, which is the coloured part of our eye. Obviously we've got brown, green, blue, and variations of that. If that angle, the opening between them is narrow, and sometimes if we dilate a patient, they might get this angle closure attack, but for some people it's very narrow and the iris and the cornea get stuck, and so fluid can no longer drain out the little channel that sits between that iris and the cornea. And so therefore their pressure rises and continues to rise because the fluid can't get out of the eyeball, and it gets very high, and we're talking over 40 millimeters mercury here. A glaucoma attack has got a nickname for bucket glaucoma because someone will feel quite nauseous, but around those sort of pressures of above 30 or above 28, people might get a little bit of redness in their eyes. When again looking at lights, they might see halos around lights. Their cornea might have a little bit of haze to it, and so that can be a symptom of glaucoma. But as I said, there's not very many actual symptoms often with glaucoma. And it manifests as an increase in mortality. Like I said, the impacts of life, of not being able to do many things, and the risk of falls from not being aware of the peripheral vision. So that's where we come in, your optometrist. So I guess this is analogous with your dentist, in that you go to your dentist for your dental appointment to look out for any problems that may arise and try avoid things like fillings and root canals. So you're looking at your oral hygiene. The same for us as optometrists. Obviously, sometimes the end point is that you might get new glasses or need glasses all of a sudden, or a different type of glasses all of a sudden, depends on what you're doing. But the actual eye exam is to assess your vision and look for things that might compromise your vision. Glaucoma is one of those, and as we said, in the long run, but glaucoma is treatable, and so that's why we are looking for glaucoma. The less damage to the nerve, the more chance we have of stopping that loss of nerve. The more nerves that are damaged, the more sort of nerve damaging factors are released by the damaged nerves, which can then damage the surrounding nerves. So dying nerves create more dying nerves. So that's why it's important. So what do we do to detect glaucoma? So this here is that angle I was talking about. So I did have a diagram. You can see in the center of the photo there's that sort of half almond shape. That is the front of the lens, and then there's those sort of cloud looking lines on the side. They are the iris, and then there's sort of a triangle vaulting. And this is actually Nicole's eye, Nicole, my wife, or the CEO of Ashburton Eyecare, as I call her. She's you'll see her quite a lot at the front office, or often on our social media, or if you're choosing frames, Nicole will help you. And you can see there a nice broad open angle there on either side of that photo. So that's what we're talking about. And where the apex of that is where all the fluid drains away. I wish I could put it. Oh, I can. If you can see my mouse there, we've got this little structure here that's called the scleral spur, and that's sort of where the white of the eye continues around the back of the eye. There's our lens there, there's our iris, and this is the angle here. And fluid comes from behind the iris. Some of it goes through the lens, others of it goes over the back of the lens. It comes up, bathes the back of the cornea. The cornea is sort of up there. And then drains out this little gap in the angle. And this is of course a cross section. This is a whole dome. So I sort of look at that when I'm on the slit lamp to make sure that angle's open. If it's a bit narrow, we can do this. And if we still find that that's narrow, I've got a contact lens to place on the eye that has some mirrors in it to look in there, and again make sure that that's nice and open. If that's not open, I will refer, and your optometrist will refer you to one of the ophthalmology department. Now, it may be an optometrist in the department that does this procedure. Some optometrists in New Zealand can do it, but generally it'll be an ophthalmologist or an ophthalmology registrar who will laser a hole, usually within one of the crypts and of your iris, and usually up underneath where your eyelid sits, to create a passage for fluid to flow through there and relieve the pressure between the front and the back, the anterior and the posterior chamber of the eye. So therefore we don't get this iris pushing up in there and getting stuck and closing that angle. So that's that closed angle glaucoma. I've got some images of what it looks like to measure the retinal nerve fiber layer. So that's all the nerves that are culminating at the optic nerve head, leaving your eye, heading off to your brain. We look at the thickness of those, compare it to some normals, and track that over time. And then we also look at all the nerve fibers coming through your central vision, through the macula, and that's the ganglion cell layer, so these are nerve fibers. And we also measure your eye pressure. If you've seen our video on Instagram, we now have the Eyecare contact tonometer, rebound tonometer, which is quite pleasant. It is a very consistent way of measuring eye pressure. We also have capability of doing Goldman pressures, which is the gold standard of eye pressures, and we have a Perkins tonometer as well. Alternatively, non-contact tonometry with the puff of air, the puff test, as that video makes fun of, is another way of measuring the eye pressure. What that's doing is seeing how much movement of the cornea happens from the various methods, and that correlates to the pressure pushing back from the eyeball. Higher eye pressures, sort of above 21 millimeters mercury, are an increased risk. Ocular hypertension, a bit like high blood pressure, is above 28, and most people have an eye pressure of 15. It is possible to still have normal pressures and have glaucoma, but all the same, they are treating glaucoma by lowering that eye pressure. So even if it's normal, they will lower your eye pressure in one way or another, and we'll get to those. So here is a tracking of Nicole's nerve again, and we can see that that's nice and consistent over time. And obviously these are quite close time points. There's a little bit of margin of error going on, so the further the time period, and obviously the more points, the better we are to see a trend. And the reason why we're looking at that is because glaucoma damages the optic nerve over time, and as we said, it can lead to visual field loss, and we want to catch that early. So if we start to see this line going downhill, then we need to really think about a referral and having that glaucoma treated. Again, some optometrists within New Zealand are glaucoma certified and can begin that treatment, but even so, they'll often consult with an ophthalmologist. This here is a visual field defect. It is quite a deep one, an inferior depression. This person wouldn't be able to drive anymore because they have a visual field. If this was across both eyes, they'd have a visual field defect within 20 degrees. And you can see there that they have lost a lot of that visual field. Their nerve is sort of, BS stands for blind spot, and they've got what's called a very deep arcuate scotoma. And they're also getting a little bit of altitude loss as well, so the top as well is starting to thin out and degrade away. So yeah, that would be a pretty nasty looking optic nerve scan and a ganglion scan, because there'd be a lot of loss of nerves top and bottom, and that's very end stage glaucoma and quite disruptive. This test we laugh is the worst computer game ever. Essentially, we're mapping what each eye can see in the case of glaucoma. If we're doing a binocular driving test, we're seeing what both eyes can see and making sure that that's not inhibited. But for glaucoma, you can see this one is what are we? I think it's the right eye. Just had to think about that. And this is what's called a nasal step and an arcuate, so it makes it arc scotoma. Where the reason why there's BS there is we flash a bright light on that blind spot, which is where the optic nerve sits, and this person managed to be looking the right way most of the time. They got 6% errors. They looked away twice. We make sure that they are seeing things correctly, and then we re-show them super thresholds, make sure that they're not clicking them just willy-nilly. So this was a good reliable scan, and that really means that visual field defect is there, which is not so good. So new treatment options. So originally it was surgery, where they basically, you can see this tube here, they basically made a hole from the front out into underneath your conjunctiva and let the fluid flow out there, and that lowered eye pressure quite well, but it has all sorts of complications and inflammation, and yeah, it's still done in extreme cases, but yeah, that's sort of what they started off with. And then, and same with tubes. Multino tube is actually was started in Dunedin. Excuse me, just having a cup of tea. And then we moved into eye drops. Especially in New Zealand, our eye drops are often preserved, and that can have complications. Also, you've got to be able to get them in your eye, sometimes twice a day. And then the active ingredients, the main one, latanoprost, is what's called prostaglandin analog, which is a form of inflammation, and that creates an inflammatory change in that drainage channel. And it works very, very well, latanoprost, but with the combination of this prostaglandin and the preservatives, that can create a little bit of side effects long term. So they are great and wonderful and available and relatively cheap, and that's why they've been so successful for so long. However, that second bullet point there, selective laser trabeculotomy, is a laser treatment that's repetitive, able to be repeated, and from a population level, the studies have shown to be as effective as latanoprost in lowering eye pressure. It means you don't need to worry about putting drops in each time, and as long as that eye pressure is staying low enough and you're still not seeing any loss of nerve or loss of visual field, the ophthalmologist is pretty happy with their work when it comes to SLT, selective laser trabeculectomy. And it's becoming more and more common as a first-line treatment. There's more and more pressure on health systems across the world to move into doing that, because, as we said, compliance is wonderful. Once the laser's bought, it's reasonably cheap, I guess, in the long term on a population level. The upfront cost, of course, is not. And yeah, if you're seeing someone privately, don't be surprised if that's what's offered to you first instead of eye drops. And that also means that you don't need to use the eye drops, or there's less eye drops you need to use. Then we have these microstents, which are often done in combination with cataract surgery. This example you can see, where's my mouse, that they have a lens implant there. The person's had cataract surgery. The front of the capsule's been peeled off. The lens material has been extracted, and the new lens is sitting there in the capsule, sitting behind the iris. And whilst they're in there, we were watching a video from Dr. Ben LaHood, who we've featured a few times on our Instagram. If you look at cataract surgery, a lot of the videos on there are of Ben's work. And we were watching a video yesterday with Hana of him doing cataract surgery and then inserting these little microstents. So they create little channels, like we were talking about, from the front out into this drainage pocket. So it's easier and lowers the eye pressure. So again, you've got a nice open angle, and you've got these little extra drainages, and hopefully the person doesn't need to use eye drops anymore, and hopefully there's enough pressure lowering to mitigate glaucoma, which is great. We've got these sort of gel stents which create an opening out there. These hydrous micro stents, again, they open up the trabecular meshwork, and there's sort of like a blade technique that they can sort of rasp along the trabecular meshwork, that channel where things drain, and that increases the outflow. And again, hopefully it means less eye drops. You don't need to set a timer every night to remember your eye drops, or morning and night to remember your eye drops. You don't need to remember to go to the pharmacy to renew your script. You don't have to contact the doctor to renew your script. So much easier in life. So as time goes on and things get cheaper and more available, and the upfront capital costs get invested in hospitals, and often in private ophthalmology first, these are often going to be the things that treat glaucoma and hopefully prevent the vision loss. So that's why it's important to come in every 2 years. If you do have some risk factors of glaucoma, don't be surprised if you're seen a bit more frequently, especially to begin with. So if we go back to our optic nerve scan, as I said, the more points we can have along there, the more reliable we can be in terms of setting a trend line. So 2 points don't make a trend. Here we've got 3 points, which is sort of starting to set a trend. And then we need time to set a trend. And the same goes for our visual fields. One visual field does not mean that there's an error in the visual field. 2 probably supports things. But if you've got 3, the software and most visual field analyzers can start to create a trend analysis and difference from the baseline, or significance of missing those little points within the visual field, and really give you confidence that yes, there is a loss of the visual field, or no, there's not. That was just a mistake in doing the test, because as I said, it was boring. And we also get the same for measuring the central vision. And so we might sort of do our initial scans, see that there's a little bit of an error in the optic nerve or in the ganglion cell, get you back to do a visual field. We might get you scanned again, so then we've got 2 points. They're pretty close together, of course. And then a month later, do the visual field and the scans again. If we're starting to get pretty normal results, well, then we might sort of go 3 months. If we're not, well, then we might go 2 months, get those 3 points. If we're still not really sure, then we might do 3 months or extend out to 6 months. And if we get pretty stable there, then we can start to sort of follow along yearly. And if we find that it's still not progressing, well, then we're back to these 2 years. Of course, we're measuring eye pressures there. Anytime there's higher eye pressures, thinner corneas, then that might sort of change our review. But of course, just having a family history of glaucoma or signs or risks of glaucoma is not the only reason to come for you twice a year. It helps us detect other things like high blood pressure in this case. If you've got blurry vision, do come into your optometrist. Like we said with the dentist before, if you've got sore teeth, you go to your dentist. If you've got blurry vision or sore eyes, go to your optometrist. It also helps us with those same scans. We can pick up macular degeneration, risks for macular degeneration, as we've spoken about today, cataracts, and then at the front of that cornea and the conjunctiva and the eyelids and stuff, we can look at dry eyes and all that is surrounded with that, as well as dystrophies and inherited stuff. Plenty of people, especially working outdoors, have pterygiums, so where the conjunctiva is growing over the cornea. Of course, we do lots at Ashburton Eyecare, keratoconus, allergies, everything. And of course, we make sure that you're seeing the best you possibly can out of your prescription. So that's sort of the call to action, is if it's been 2 years, it's time to book in again. Don't wait, because as we said, when it comes to glaucoma, it's the silent thief of sight, so you won't necessarily know about it until it's far too late. You can schedule your eye exam online, and together we can make sure that you're seeing the world to the best of your ability.